Hello everyone. Today's topic of discussion is homocystinuria. This is an inborn error of metabolism, that is methionine and cysteine metabolism. Methionine and cysteine metabolism. These are the sulfur containing amino acids. Methionine is converted into cysteine, and during this conversion one of the enzyme is deficient that leads to the homocystinuria. It is an autosomal recessive disorder. It is an autosomal recessive disorder. There are four main types, or you can classify the homocystinuria into classical homocystinuria or non-classical homocystinuria. So classical homocystinuria, it is due to defect in the enzyme cystathionine β-synthase. This is due to defect in the enzyme, that is cystathionine β-synthase. And non-classical homocystinuria, it is mainly due to defect, defect in methylcobalamin synthesis, due to defect in methylcobalamin synthesis, or due to defect in N5 and 10 methylene tetrahydrofolate reductase. So these are the two main types of homocystinuria, that is classical and non-classical. Before going to the discussion of homocystinuria, you must know the methionine and cysteine metabolism. So let's discuss methionine and cysteine metabolism. In this metabolism, or in this metabolic pathway, methionine is converted into S-adenosyl methionine, SAM. S-adenosyl methionine, it is an active methyl group donor, SAM. Okay, S-adenosyl methionine, it is an active methyl group donor. So methionine in this reaction, with the help of methionine adenosyl transferase, remember this as MAT, methionine adenosyl transferase. Methionine adenosyl transferase, there is transfer of adenosine from ATP. There is transfer of adenosine from ATP. So ATP plus water molecule, it is converted into inorganic phosphate and inorganic pyrophosphate, and adenosyl is transferred to form S-adenosyl methionine. Okay, methionine adenosyl transferase. The enzyme is methionine adenosyl transferase. Now this S-adenosyl methionine, it is converted into S-adenosyl homocysteine. S-adenosyl homocysteine, and this is methyl transferase reaction in which the methyl group donated by the SAM, the methyl group which is donated by the SAM, it is accepted by an acceptor and converted into methylated product. For example, take one example, norepinephrine. There are number of examples of methylation reaction. Norepinephrine is converted into epinephrine, epinephrine is converted into metanephrine, the gonadioacetate is converted into creatinine, the ethanolamine is converted into choline. So a lot of examples are there. N-acetyl serotonin is converted into melatonin. So transmethylation reaction is there. So methyl group, it is accepted, it is converted into epinephrine. So these are the transmethylation reactions. So with the help of methyl transferase enzyme. So here methyl transferase. Now this S-adenosyl methionine, it is converted into homocysteine. Is converted into homocysteine with the help of adenosine homocysteinase. It is with the help of adenosine homocysteinase. Cysteinase is converted into, so here adenosine is removed and this homocysteine is converted into methionine. Okay, homocysteine is converted into methionine. For this reaction, this is very important reaction. It is related with vitamin B12, it is related with the folic acid, it is related with the folate trap, and it is related with non-classical homocysteine urea. So in this reaction, the reaction is catalyzed by methionine synthase. Methionine synthase enzyme. In this reaction, methyl tetrahydrofolate is converted into tetrahydrofolate. So B12 is required for this reaction. B12, methylcobalamin, is required for this reaction. Okay, so B12 and folic acid dependent reaction in which methyl tetrahydrofolate is converted into tetrahydrofolate with the help of methionine synthase. This is the formation of homocysteine, and homocysteine is converted into methionine. In the next reaction, homocysteine, this homocysteine condenses with serine to form cystathionine. And this cystathionine is converted into cysteine plus homoserine, and this homoserine will give propionyl coenzyme A. Now the important reaction here is this one. This is catalyzed by cystathionine beta synthase transsulfuration reaction. Cystathionine beta synthase, it is an PLP dependent reaction. Pyridoxal phosphate is required for this reaction. Also the next reaction is cystathioninase. It is also pyridoxal phosphate dependent reaction. These are the transsulfuration reactions dependent on pyridoxal phosphate. So homocysteine condenses with serine to form cystathionine, and cystathionine is converted into cysteine and homoserine. Now defect in cystathionine beta synthase, this enzyme, the important enzyme cystathionine beta synthase. This is an important enzyme, cystathionine beta synthase. Defect in this enzyme causes classical homocysteinuria. Is classical homocysteinuria, also known as homocysteinuria type 1, classical homocysteinuria due to cystathionine beta synthase defect. The deficiency of cystathioninase, it causes cystathionininuria. It causes cystathionininuria. Okay. Now this enzyme, that is defective synthesis of this B12, methyl B12 synthesis, causes non-classical homocysteinuria. This is non-classical homocysteinuria, defect in synthesis of methyl B12 and defect in the synthesis of this methyl tetrahydrofolate. It is synthesized from the N5 N10 methylene tetrahydrofolate with the help of enzyme. This is with the help of enzyme N5 and 10 methylene tetrahydrofolate reductase. This is an important enzyme, and defect in this enzyme causes non-classical homocystinuria, that is homocystinuria type 2. Non-classical homocystinuria, that is homocystinuria type 2. Now see the classical homocystinuria. In this classical homocystinuria, there is decrease, see defect is here. So here is the defect, that's why there is decrease in the cysteine. Cysteine level decreases in the classical homocystinuria, while homocysteine level increases. So there is increase in the homocysteine level, and homocysteine is converted into, see this reaction, homocysteine is converted into methionine, so methionine level increases. So coming to the homocystinuria discussion, see there is decrease in the cysteine level, increase in the methionine, there is increase in the homocysteine level in the blood. There is increase in the homocysteine level in the blood. There is increase in the homocysteine and homocysteine both in the blood, but in the urine it is excreted in the form of homocysteine. So homocysteine level increases in the blood, also homocysteine level increases in the blood, but in urine it is excreted in the form of homocysteine. Okay, homocysteine. It is excreted in the form of homocysteine, that is containing disulfide linkage. So it is excreted. So these are these amino acids, cysteine, it is decreased, and methionine and homocysteine level increased in the classical homocystinuria. Classical homocystinuria. Now what are the clinical features of classical homocystinuria? The clinical features includes, the clinical features, the neonate or infant is normal. It is normal at the birth, and symptoms develop over the period of time at the age of 3 years. The symptoms develop at the age of 3 years, mainly at the age of 3 years. Okay. So what are the main symptoms? There is mental retardation, that is progressive intellectual disability. Mental retardation in the form of progressive intellectual disability. Then the important feature and key feature of this disease is ectopia lentis. What is the meaning of ectopia lentis? Ectopia means subluxation of the lens occurs because this homocysteine, it interferes with the collagen formation. So there is the subluxation of lens occurs. So ectopia lentis means subluxation of lens, and because of subluxation of lens there is myopia and iridodonesis. So iridodonesis meaning uh, the queering of the iris or the tremors in the iris, that is known as iridodonesis. Iridodonesis and myopia, these are the features due to ectopia lentis, due to the subluxation of lens. So the suspensory ligament of the lens is involved. So as there is defective collagen synthesis because of excessive level of homocysteine, there is subluxation of lens occurs. Also there are skeletal abnormalities. So tall and thin child tall and thin child, the long digits and limbs, long digits and limbs. It can compare with the Marfan syndrome. Marfan syndrome like features are there. So tall and thin child, long digit and limbs, that is archanodactyly is there, and the skeletal abnormalities, that is genu valgum. Genu valgum means gum. Gum means stick together. Knees are stick together. Okay. Genu valgum. Then the chest deformities. Then gait disturbances are there. Gait disturbances. Okay. So child will present with failure to thrive, means difficulty in weight gain and developmental delay. Okay. So there is failure to thrive and developmental delay. Then mental retardation, ectopia lentis, that causes the myopia and iridodonesis. Then skeletal abnormalities like tall and thin child, the long digits and limbs, genu valgum, chest deformity, and gait disturbances are there in the classical homocystinuria. How will you diagnose a case of classical homocystinuria? By doing the amino acid profile by the chromatography. Okay, by the chromatography or tandem mass spectrometry. So laboratory diagnosis by the homocysteine, homocysteine in urine. It is done by the cyanide nitroprusside test. Cyanide nitroprusside test, which is positive in the patient with homocystinuria. Then amino acid profile, that is homocysteine, cysteine, homocysteine, methionine levels can be detected by the chromatography. Confirmatory diagnosis can be done by the tandem mass spectrometry or can be gas chromatography mass spectrometry combination. The confirmatory diagnosis can be done by this test. Also the enzyme analysis can be done. Enzyme analysis, that is cystathionine β-synthase analysis can be done. So this is lab diagnosis. Now there is frequent episodes of thrombosis in patient with elevated homocysteine level. There is increased thrombosis, that is increased chances of coronary artery diseases or increased chances of atherosclerosis in patient with elevated homocysteine level. Why? Homocysteine, when it is elevated, so increase homocysteine level, it interferes with collagen formation. So interferes with collagen cross links. It interferes with the lysyl residues of the collagen cross links. So interferes with the lysyl residues of the collagen cross links and interferes with the collagen formation. It leads to the formation of reactive oxygen species, that is homocysteine thiolactone. It leads to the formation of homocysteine thiolactone, that is it leads to the formation of free radical formation, that is homocysteine thiolactone. And this homocysteine thiolactone, that free radical, causes the formation of oxidized LDL, or it causes the thiolation of LDL particles, that is responsible for aggregation of LDL. Low density lipoprotein. As the aggregation of low density lipoprotein occurs, that results in the formation of foam cells, foam cells, and atherosclerosis. So it can cause the cerebrovascular disease, it can cause the stroke in the brain, it can cause the atherosclerosis. This is because of increase in the homocysteine level. This can be compared with the 5 micromole per liter micromole per liter increase in the homocysteine level can be compared with the increase in the cholesterol level by 20 mg/%. It can be compared with the increase in the cholesterol level by 20 mg/%. It increases the risk of coronary artery diseases, atherosclerosis, because it interferes with the lysyl residue of collagen crosslinks, results in the formation of free radicals. These free radicals thiolates the LDL particles. The oxidized LDL formation or free radical which causes the oxidized LDL formation tends to aggregates, and aggregation of LDL, it is taken by the macrophages to results in the formation of foam cells and atherosclerosis. That's why increased homocysteine level, it is related with the atherosclerosis. So what should be given in the treatment of homocystinuria? In the treatment of homocystinuria, so first B6 pyridoxal phosphate should be given. B6 pyridoxal phosphate, because cystathionine beta-synthase is PLP dependent enzyme. Then the cysteine should be supplied in the diet. Cysteine should be supplied in the diet. Cysteine in diet. Then methionine should be avoided. Methionine should not be given, or methionine should be avoided. The commercial preparations are available. The methionine free and cysteine containing diet should be given to the patient with homocystinuria. Then betain. Betain causes the increase the conversion of homocysteine to methionine. So it decreases the homocysteine level. So betain can be given in the diet, and mega doses of vitamin C can also be given in the treatment. Okay, so pyridoxal phosphate should be given, cysteine should be given in the diet, methionine, as there is already hypermethionemia, so methionine should be avoided in the diet. Betain, that causes the conversion of homocysteine to methionine, it should be given, and mega doses of vitamin C should be given in the patient with homocystinuria. Those who are not responding to B6 therapy, the vitamin B12 and folic acid can be given in the treatment. Vitamin B12 and folic acid. So how vitamin B12 and folic acid will help? How they will help? See, the non-classical homocystinuria, it is because of methyl B12 deficiency and due to defective synthesis of methyl tetrahydrofolate. So non-classical homocystinuria. Got it? So whenever it is due to methyl B12 defect, non-classic homocystinuria, the symptoms are like megaloblastic anemia due to defect in methyl B12 synthesis. The symptoms are of megaloblastic anemia, and there is in this non-classic homocystinuria, there is decrease in the methionine level. So there is hypomethionemia. There is decrease in the methionine level. So this is the differentiating point between homocystinuria classical and non-classical. There is decrease in the methionine. Again, whenever there is deficiency of N5-N10 methylene tetrahydrofolate reductase, there is also decrease in the methionine level. So hypomethionemia is there in this deficiency, in B12 methyl B12 deficiency and this enzyme defect, methylene tetrahydrofolate reductase deficiency. Okay, this is also known as homocystinuria type 2. This is known as homocystinuria type 2. Okay, so in this non-classical homocystinuria, the B12, methyl B12 and the folic acid is important. It can help in the treatment. Now the next one related to this topic, that is cystathionine. It is presented with mental retardation, anemia, thrombocytopenia, The cyanide nitroprusside test is negative in cystathionine urea. Okay, cyanide nitroprusside test is because of homocysteine level in the urine, homocysteine level in the urine. So cystathionine urea, mental retardation, anemia, thrombocytopenia. This is due to the defect in cystathioninase, which is also pyridoxal phosphate dependent enzyme. So we discussed 4 disorder here. We discussed 4 disorder. One is the homocystinuria, that is classical cystinuria. Then second one is the non-classic, that is non-classical homocystinuria. Then cystathionininuria. Okay, so these are the 4 disorders. In non-classic homocystinuria, one is because of methyl B12 deficiency, and another is due to N5 and 10 methylene tetrahydrofolate reductase deficiency. So these are the 4 disorders we discussed. In homocystinuria, classical homocystinuria, the clinical features are, that is failure to thrive, developmental delay, ectopia lentis, skeletal abnormalities, long digit normality, long digit, tall stature, long digit, then the genu vulgum deformity, then the gait disturbances are there, then osteoporosis or decreased bone mineral density, and porosis, and frequent fractures. These are the symptoms. There is elevated level of methionine, homocysteine. There is decreased level of cysteine in the blood. In the non-classic homocystinuria, this will manifest as, due to methyl B12 deficiency, this will manifest as megaloblastic anemia. There is decrease in the methionine level. Methionine level decreases, and cysteine levels are normal. N5 and 10 methylene tetrahydrofolate defect, there is no megaloblastic anemia. Okay, no megaloblastic anemia. There is decreased methionine level. Then cystathionine urea, it is because of defect in the cystathioninase. This is also pyridoxal phosphate dependent enzyme. The defect in the cystathioninase causes mental retardation, anemia, thrombocytopenia. Okay. So cyanide nitroprusside test is negative in this patient. Here this test is positive. Cyanide nitroprusside test is positive. Okay. So cystathionininuria, mental retardation, anemia, thrombocytopenia, and negative cyanide nitroprusside test. Okay. So these are the 4 different disorders we discussed today. Main is the homocystinuria due to cystathionine β-synthase defect, pyridoxal phosphate dependent enzyme. There is decreased cysteine level, increased methionine level, increased homocysteine level, and accumulation of methionine and cysteine causes the symptoms that are the mental retardation, that is progressive intellectual disability, Then the skeletal malformation, ectopia, lentis, that causes myopia and iridodonesis, and gait disturbances are there, also known as Charlie Chaplin gait. Okay, so gait disturbances are there in the classical homocystinuria. It can respond to the mega doses of pyridoxal phosphate. Also, betain is given in the treatment. Vitamin C is given in the treatment. Then cysteine should be provided as cysteines are low, and methionine should be avoided in the diet. The classical feature is ectopia lentis, that is the subluxation of lens, and thrombotic episodes are there in the homocystinuria because of elevated homocysteine level. Okay, so there is increase in the homocysteine and excretion of homocysteine in the urine. Homocysteine contain the disulfide linkage and homocysteine contains sulfhydryl group. So this is all about the homocystinuria. Keep watching. Thank you.